Radiology for neuroradiology. When you get a CT or an ultrasound, you see calcifications in a little baby's brain. You have to worry about the torch infections. You can also worry about maybe tuberous sclerosis. But when you see these little punctate, deep white matter stuff, this is CMV. The CMV and toxo are your big ones that you worry about for torch. CMV is periventricular calcifications are common secondary to prior cerebral inflammation. They get enlarged ventricles due to actual cerebral damage. And the differential is congenital toxo. These calcifications are usually more scattered, and ventricular dilatation and toxo is due to true hydrocephalus as opposed to cerebral damage. Tuberous sclerosis or calcified tumors, usually larger and fewer. These subepineural tumors frequently do not calcify until the patient is a little bit older. So in a little baby, you really worry about the torch, CMV and toxo. And toxo is a pregnant woman that sniffs the cat litter. So a pregnant woman should be nowhere near cat litter. This is a different patient, and these are bigger, coarser calcifications, and this patient had toxo. This is one of your neuronal migration disorders. The big ones that we know are, what is this one? Schizencephaly, and what to be exact, what would you call it? Open lip. Open lip means that look at this huge space here. Closed lip, this edge would be abutting that edge. This defect is lined by abnormal gray matter. There's abnormal gray matter right in here, and it'll always go from the outer part all the way to the ventricle. So this is schizencephaly, schizencephaly, like a hatchet. Yeah, 1668. Can you call 1668 for me? I don't know what it is. So this is these patients could present with seizures. Like I said, it's a neuronal migration disorder. They have a transcerebral cleft from the lateral ventricle to the cerebral surface. It's lined by abnormal gray matter, maybe unilateral or bilateral. Yeah, the most common place was there, mid-hemispheric level near the central sulcus, and they may present with seizures. This is a different patient. We see this sometimes on a neonatal ultrasound, but we can't call it if the kid's less than 28 weeks gestational age because sulci usually don't start forming until about 28 weeks. But this is a smooth brain. It's like a figure of 8 brain. It's called what? Lissencephaly, smooth brain, Lissencephaly. Is when the sulci start, the gyri and the sulci start forming. Neuronal migration disorder during the 12th to 24th week of gestation cannot be reliably made until after the 26th, 28th week of gestation when the normal gyri and sulci become well defined. It's a smooth, slick brain, thick cortex with lack of normal gyrations, shallow sylvian figure of 8 appearance. They get hypoplasia of the white matter, enlarged dysmorphic ventricles. They can have mental retardation, mentally challenged. They can have seizures, difficulty swallowing, failure to thrive, muscle spasticity, developmental delay, and they can have microcephaly.
So aren't gyrations your patent advancement?
Possible causes for Lissencephaly, it could be due to a viral infection during the first trimester, or insufficient blood supply, or maybe a genetic mutation, especially of chromosome 17 and the X chromosome. But who knows exactly why. A milder variant of this is called pachygyria, when the gyri look really thick. Here is MRI, and what do you see? What is this? Yes, this is heterotopic gray matter. This is gray matter where it shouldn't be. It will on all, what was it?
It's not for you.
It wasn't for me?
It was for body, not for feet.
Oh, thank you. Whatever, if you do CT, if you do ultrasound, if you do MRI, if you give contrast, it will act like gray matter. It'll be the same sequence, same signal, same attenuation, echogenicity as gray matter. It's just an abnormal spot. This can be a common thing that you might see. They might show you on the boards, or you might see in real life, is in the periventricular region, these little nodules around outside in the periventricular regions, little nodules of heterotopic gray matter. And so heterotopic gray matter is another neuromigrational disorder. May show amorphous islands within the white matter versus nodules along the ventricular surface, just like I told you. It may be bilateral symmetric or it could be unilateral. May show mild enhancement, but it should do the same as the cerebral cortex. Here you have plain films. Dr. Nall has said this for years, and I have said it for years too, but Dr. Nall is older than me, so she said it for more years. The residents, y'all get very trained and love high-tech stuff. You love ultrasound, but not as much as you like MRI and CT and angio. Well, some people don't like angio, and PET, and all these high stuff. But the majority of radiology is plain film. The majority are plain films. You guys don't get excited about plain films. It's like, oh crap, I got to read this. And so Dr. Nall will say it, and I say it. There's a lot of stuff you can find on a plain film that can diagnose things besides what they're looking for. Chest X-ray, you can diagnose chronic pancreatitis, but if you look really close in the upper abdomen, you'll see the calcifications. In this case, you see this is a skull film. They rarely do skull films anymore, but here it's just off midline. There's this curvilinear calcification, and here it is again. And you would say, well, maybe there's a little bit of lucency in here. Maybe that's not real. Maybe that is real. So what you could do is if you saw this, you would go to a CT. And in the CT, it shows this calcification. And this is not CSF. This was actually like minus 100. So this is fat. What lives here? Corpus callosum. What can corpus callosums get? Lipomas. What do lipomas often do? They can calcify. So this was a calcified corpus callosal lipoma, and they can also get partial agenesis of the corpus callosum. So if you see a corpus callosal lipoma, there may be partial agenesis of it. Here's the MRI, the T1 weighted image, and it's increased density, increased signal because it's fat, and it's right in the corpus callosum. Here is partial agenesis of the corpus callosum. You see how there's nothing here. Do you know, guys, the seniors that are going to take it, what is this structure? That's the tectum. That's the tectal plate or the quadrigeminal plate. That's the quadrigeminal plate. What is this black thing? That black area. That's the aqueduct of Sylvius. What is this of Sylvia right there? Hi, Sylvia. How's your aqueduct? I hope it's small, but not big, but not closed. What is this called right here? This is the tectum. This is the tegmentum. What is this right here? Mammillary body. Correct. What is this right here? The optic nerve. The nerve is from here, and then when it gets behind the chiasm is the tract. Very good. And what is this right here? The massa intermedia or the interthalamic adhesion. When you're midline, the thalamus are all off midline. This is the massa intermedia or the interthalamic adhesion. Okay. When you see this, this is all, this could easily be on your boards, and they're going to just show you this one image, or they might show an ultrasound that looks just like this. This tells you what? Agenesis of the corpus callosum, because you have parallel ventricles. When you have parallel ventricles, you have agenesis of the corpus callosum, and often you'll have, what's it called when the occipital horns get big? Colpocephaly. Very good. And the reason is you don't have the corpus callosum. The corpus callosum is the midline structure, connects the left brain to the right brain, and underneath it's the third ventricle. So look, my third ventricle can't go any higher because I have my corpus callosum. You don't have the corpus callosum now, it can go higher. The third ventricle can go higher, and what it does is it straightens to the frontal horns, or like this. Well, when it goes higher, it pushes the frontal horns out, so now the frontal horns become parallel. So parallel lateral ventricles is agenesis of the corpus callosum. Absence of the entire portion, or just you can have partial agenesis. And it allows, like I said, the third ventricle to rise, and it moves the frontal horns out lateral. So you're going to get wide separation of the lateral ventricles. Another sign they might show you is on a coronal, the longhorn sign, when it looks like the frontal horns are doing like this, because that's another sign of it. This, I don't know why this looks so dark, but Here you can see the upper half of the cerebellar vermis, but you don't have the lower half. I don't know why it's doing this, because it looks good here, looks terrible there, looks terrible here. But here, it communicating with a big old cyst, and here you can see there's a big posterior fossa cyst. So this is in the what family? Dandy Walker family, Dandy Walker malformation. What's the mildest spectrum? Dandy Walker is the worst. Then you have the Dandy Walker variant, and then you have, it's called a megacisterna magna, and everything is good. It's just below the vermis of the cerebellum, the fluid, the cisterna magna is a little bit prominent.
So it's megacisterna magna variant, and then full-blown
Yeah,
Dandy
yeah.
Walker.
And in the variant, you'll have like partial agenesis or partial dysplasia of the vermis, the lower half, so that the fourth ventricle does go into this posterior fossa cyst. But in the real Dandy Walker, the full Dandy Walker, almost all of the vermis is gone. You only have a little bit hypoplastic cerebellar tissue that's way separated. You have a huge posterior fossa, and there's a huge cyst. In the variant, it might be normal. The posterior fossa size might be normal.
In all the questions, they like to talk about orcular inversion. Orcular landoid inversion.
And what's the question? What is that?
Basically, you just have to know that the tentorium rise up on this one, and so like whenever you see it on an MRI, it's the orculum where all the sinuses come together.
It'll look like this. I mean, like it'll be like
It'll be
like
reversed
this?
in terms of position with the landoid suture. They'll switch position.
So here is an MRI, and you can see this is part of the vermis. You can see the connection with this huge posterior fossa cyst. You get hydrocephalus. You get the lateral ventricle is big, the third ventricle is big. And here, this was bad Dandy Walker. Yep, Dandy Walker. Posterior fossa cysts are Dandy Walker malformations. The variant is hypoplasia of the posterior inferior vermis, allows communication of the fourth ventricle with the cisterna magna. Cystic dilatation of the fourth ventricle with a normal size posterior fossa. This is big posterior fossa, this is a normal size. And then the megacisterna magna is the least common. You can get arachnoid cysts in the posterior fossa, especially at the CP angles. Where's the most common place for an arachnoid cyst? Anterior portion of the middle cranial fossa, anterior to the temporal horn. You can also get it in the suprasellar cistern, and you can get it at the CP angles. Dandy Walker is a large posterior fossa with a high tentorial position. Dysgenesis, agenesis of the vermis with very small separated abnormal cerebellar hemispheres. Cystic dilatation of the fourth ventricle filling almost the entire posterior fossa. Associated with agenesis, dysgenesis of the corpus callosum, holoprosencephaly, syringomyelia. What is a syrinx, guys?
Syrinx is a dilatation of the central spinal canal. Where you have
Are you going like this, or are you going like this?
I thought it was
Hydromyelia is the dilatation of the central canal. Syrinx is a cord substance destruction. So we often can't tell, so we call it syringohydromyelia. But hydromyelia is when the central canal is dilated. Syrinx is a tract, a CSF tract in the cord substance due to destruction of the cord. And when you have a syrinx, you have to worry about, there's three big things you have to worry about. It could be what are causes of a syrinx? Chiari have syringohydromyelias, syrinx. Chiari, trauma, and tumors. So you have to give contrast when you do the MRI of the spine because you want to see if there's an enhancing mass that's causing it. These can also get occipital encephaloceles, polydactyly, cardiac anomalies, and cleft palate. Here we have a falx. We have a single ventricle. We don't have a septum pellucidum, but we are getting separation of right and left. So this is a what? This is lobar holoprosencephaly. Which one's the worst? Alobar. Alobar holoprosencephaly is the worst. So here there's actually a falx. It's trying to make one, but none of them of the holoprosencephalies have what?
None of the holoprosencephalies have
The septum pellucidum. Just like all Lefort fractures have fractured the pterygoid plates. Absolutely. If it's not, it's not. If there's a septum pellucidum, it's not due to holoprosencephaly. This is the alobar type. There's no midline differentiation. You got the huge monoventricle. These are the ones that have midline defects. They could have a.
How do you tell semi-lobar?
Yeah, don't you have to?
It can have a little bit of different. It's between the two. It's got a little bit of a differentiation of that. It's a little bit tougher.
Don't you
It's
have to know the difference, you have to show a picture of the valves,
to see if they're fused or not.
or else it could be either.
But if you have a little bit of a like maybe the midline separation in part of the brain, but not all the way, that would be semi-lobar. Lack of cleavage of the forebrain during the 6th week of gestation with arrested growth of the lateral ventricle resulting in a monoventricle. Septum pellucidum is absent in all of them, all forms. The alobar, no hemispheric development. Semi-lobar, some hemispheric development. Lobar frontal and temporal lobation with a small monoventricle. This almost could be septo-optic dysplasia. You ever heard of that? Septo-optic dysplasia is when they lack a septum pellucidum and their optic nerves are small. So if the optic nerves were small, like in that first one that I showed you, and there was no septum, it could have been septo-optic dysplasia. 60% will have polyhydramnios. They have renal and cardiac anomalies, chromosomal abnormalities, especially 13 and 18. And the alobar type can have a single digit, the cyclops. This patient, what you see here, you see the faults, you see this, quote, horrible hydrocephalus, right? But do you see cortex?
No.
So if there's no cortex, is that hydrocephalus? It's not. It's hydranencephaly. And what's that due to? In utero. In utero is ischemic insult on the internal carotid arteries. And so what happens is where the internal carotid arteries supply the most of the cerebrum, except the back part of the back inferior part of the occipital, that all the rest will be gone. This is not severe hydrocephalus, because if there's severe hydrocephalus, you'd still see a little bit of cortex being squashed around the periphery. There's no cortex here. All the cortex is gone. But you remember the vertebral arteries make the basilar artery, and then it comes and ends in the posterior cerebral artery. The end of the basilar artery is the posterior cerebral. So the posterior cerebral part, which is the occipital part, will be there. And you'll have your brainstem, you'll have your cerebellum, you just won't have the majority of your cerebral cortex. And this is like the, quote, waterhead, and if you shine a light, it'll go all the way through because there's no brain interfering with it. Here's the MRI that shows absolutely no cortex. You just see the faults, but you have your brainstem, and you can, like I said, you can have a little bit of the posterior inferior cerebellum. Hydranencephaly, absence of the supraclinoid ICA system, possibly vascular occlusion, infection, CMV toxo, which causes necrosis. It's not compatible with prolonged life expectancy. Here, this is Aunt Minnie. This is a skull film, frontal and lateral views of the skull. This is Sturge-Weber. Do you see that? What are these calcifications? Are these in the brain parenchyma? These are in the leptomeninges. And do you see? Are they going all the way to the edge? All the way to the skull? Why aren't they? Because that side of the brain is what? Hemiatrophy. That side of the brain is atrophic. So they get hemiatrophy on that right side. What else? What are they? If I had it, what would I probably have? Port Weinstein, a big purple bluish lesion right here. Remember Kathy, the CT tech, Bernal? She probably had it. No, because she had this huge purple, thick purple Port Weinstein. What is the triad that they get? No, I'm sorry. Forget it. I'm messed up. Sturgeon, what's another name for it? No. That's encephalotrigeminal angiomatosis, because they're angiomas that calcify. They get the Port Weinstein, ipsilateral venous angioma of the meninges. It could also be called tram track calcifications there, associated with epilepsy, hemiatrophy of the brain, and mental retardation. Kathy was not mentally retarded, so they don't have to be mental retardation. I don't know if she had seizures. I don't know. Nobody would go up, you don't want to ask people. But these patients classically will have seizures, mental retardation, and hemiatrophy. and it's a neurophacomatoses. What other neurophacomatoses do you know? Tuberous sclerosis, neurofibromatosis, very good. And what do you see here on the CT? Subependymal calcifications, probably in subependymal tubers. So what does this patient have? Are these tubers malignant? No, they're not, but what can happen to one of them? What's the SEGA? Giant cell astrocytoma, and which one is most likely to do that? Which location? The anterior portion of the third ventricle near the foramen Monroe. That's the one that's most likely, if any of them, to degenerate into a giant cell astrocytoma.
Anterior portion of the third ventricle.
Right here, you see it? That's the giant cell right here. And this is right near the foramen Monroe. It's in the anterior. This is right where colloid cyst's favorite spot is. And the colloid cyst is a benign tumor. Benign. It's just it's not it's a tumor because it's a growth. It's a colloid cyst. It's just the worst place that it could possibly be. And those, classically, those patients have positional headaches. And they can pass out because when they turn their head, the colloid cyst can block the foramen Monroe. They get temporary hydrocephalus. They get a headache and they pass out. And so these patients can get hydrocephalus too because it's in a bad place. What is the triad of this, of tuberous sclerosis?
Fits, nitwits, and zits.
Zit, okay, this is not to be politically incorrect. This is to help you remember. Zits, fits, nitwits. Zits are adenosebation shagreen patches. Fits are seizures. Nitwits is mental retardation. And people don't like the word retardation anymore, so I don't know what they call it, mentally challenged, or I don't know. But don't go telling patients zits, fits, nitwits, or your husband and your wife, your strangers. That's just for you in your head to remember, so when you take a test, these are my three things that I got to worry about. And this is tuberous sclerosis. And what does tuberous sclerosis, what else do they get in the body? What do they get in the kidneys? They get angiomyolipomas in the kidneys. What do they get in the heart? Rhabdomyomas in the heart. And sclerosis, they can get sclerotic bone lesions. So tuberous sclerosis, also known as Bournville's disease, one of the neurophacomatoses. Epilepsy, mental retardation, adenosebation of the face, and a butterfly distribution. Autosomal dominant. The subependymal calcified tubers may also get parenchymal calcifications. Tubers near the foramen Monroe can degenerate into the giant cell astrocytoma. So just they're in the third ventricle near the what?
I think it's almost spelled in
What?
It's not Monroe, like the city.
You would like foramen of West Monroe.
That's right.
Hamartomas occur through the body. Kidneys get angiomyolipomas. Liver, thyroid, and no ovaries can get hamartomas. Rhabdomyomas of the heart. Retinal tumors, which is the phacoma. Here we have a posterior fossa cyst with an enhancing mural nodule. So you can see it right here. It's a hemangioblastoma. And what kind of patients get these? Von Hippel-Lindau syndrome, absolutely. And this is a common place for it in the cerebellum. The differential for this would be a pilocytic astrocytoma. On this right here, they have to take that little mural nodule out. They have to make sure they get it or it will recur. And von Hippel-Lindau, they can get these in the spine as well. So you want to make sure you give contrast. Retinocerebellar angiomatosis. Autosomal dominant, presents in the second, third decade. Retinal angiomatosis. So I guess phacoma, does phacoma mean eye stuff? Is that what the word phacoma means? I don't know either. Retinal angiomatosis, the earliest manifestation of this disease is retinal angiomatosis. So it presents in the second, third decade of life, so the ophthalmologist might be the one that sees it. They get hemangioblastomas of the CNS, which are benign non-glial tumors. Cerebellum is the most common place, then the brainstem, then the spinal cord. And 75% of these will be large cystic lesions with an enhancing mural nodule. They don't calcify. The heart, they get rhabdomyomas also. Kidneys get renal cysts, but here's the big one. They can get renal cell carcinoma. So if you have a kid with a renal cell carcinoma, you got to worry, do they have von Hippel-Lindau syndrome? Because why would a kid get renal cell? The patients with sickle cell trait disease, so much more than sickle cell disease, patients get what kind of tumors in the kidneys? We talked about that yesterday, John. Renal medullary carcinoma. A patient with sickle cell trait, if you see a mass in the kidney, you think, could it be renal medullary carcinoma? Is that prognosis-wise with Wilms and renal cell? What is it? Worse, better, same? It's worse. It's worse. Renal medullary carcinoma is terrible. So these kids get renal cell. These kids, young adults, can get, and maybe bilateral. They can get renal adenomas, renal hemangiomas, but not angiomyolipomas. The adrenals can get pheochromocytomas. The epididymis can get cystadenomas. Pancreas can get cystadenomas, cystadenocarcinomas, islet cell tumors, hemangioblastomas, and cysts. Liver can get hemangiomas or adenomas. They can get paragangliomas. They can get cysts in almost any organ.
Differentiate that from JPA, the polycytic astrocytoma.
Oh, polycytic astrocytoma.
Because that's like the buzzwords for a JPA
That's
as well, cystic with an enhancing nodule.
That's the best tumor to get, and I guess they would have all these other symptoms, all these other signs, but the best prognosis brain tumor in a kid is polycytic astrocytoma, and that's usually in the cerebellum. And maybe Google that after this lecture and let me know. Let everyone know. They can all Google.
More often midline, another one is.
Well, midline is medulloblastoma. Both are usually in the cerebellum hemispheres. The medulloblastoma is.
Maybe JPA is more usually lateral. I'll look up.
Okay. Here is a patient, different patient, and what do you see? Cerebellar tonsillar herniation is kind of a V shape. It's kind of pointed, and it goes like more than 3 or 5 millimeters below the skull base. So this is tonsillar herniation. And if there's no myelomeningocele, there's nothing else. Maybe there's a syrinx, maybe there's not. What is it? Chiari-1. And these are usually asymptomatic. You might have it right now. If they're symptomatic, they'll go and they'll cut this bone off, the back of the occipital bone right here, to give it more space. But it's if the tonsils are nice and rounded, that's probably not tonsillar herniation. These are going to be more pegged-like or pointed. And in the old days, before MRI came around, they used to do like arteriograms, and they would see the vessel get looped down there. But that's how they would diagnose in the old days, before my time, hydrocephalus. They didn't have CT back then. They put a catheter in there and put contrast, and they would see that the artery that goes right over the corpus callosum would be way up high, and they would look at I forget what that triangle was called, but in angio there was a triangle, Sylvian triangle. That would be the angiographer would really look for that. So Chiari-1, this is a huge occipital or cervical encephalocele. You do an MRI because you want to see how much brain tissue goes in here. And when you have this, you worry about what? Chiari-3. Chiari-3 has encephaloceles or upper cervical encephaloceles. And in the Western Hemisphere, they're usually in the back, in the occipital region. In the Asian countries, they're usually in the frontal. So if you have a cystic lesion, like in the nose, you have to worry, could that be an encephalocele? You don't want to go have them put a needle in it or biopsy it, because you need to make sure you work it up, because it could be an encephalocele that went down into the nasal cavity. Chiari-3 can have Leukenschädel skull, which is the little, but beaten brass appearance, hindbrain malformations, occipital cervical myelomeningocele or encephaloceles. And Chiari-2 is the Arnold Chiari. We used to say Arnold Chiari-1, Arnold Chiari-2, Arnold Chiari-3. Arnold Chiari is Chiari-2. Okay, that's Chiari-2. And that's the one we have the tonsillar herniation, more than 3 to 5 millimeters. They have spinal abnormalities in more than 95%, and it's going to usually be a lumbar myelomeningocele. And they'll have a syrinx. Type 1 can have a syrinx, but type Chiari-1 is not going to have a myelomeningocele, nothing else. They get obstructive hydrocephalus. They can have corpus callosal agenesis. They'll have absence of the septum pellucidum in 40%, and they'll have the beaked tectum for Chiari-2. And what is the two signs on an OB ultrasound that is Chiari-2? And they are both food. The banana sign is when the cerebellum wraps around the brainstem because it's a real small posterior fossa. Danny Walker has a huge posterior fossa. Chiari-2 has a real small posterior fossa because the cerebellum is kind of herniating down through the foramen Monroe. And then they have the shape of the head is a lemon head. So they have a Chiari-2. So if you see a lemon head or in the banana sign, that's Chiari-2. What if you see, what's the Spalding sign on an OB ultrasound? That's fetal death, and that's overlapping sutures. When the baby dies, the fetus dies, the sutures will overlap, and they're supposed to be like this. They'll overlap, and that's a Spalding sign, and that's fetal death. Chiari-1 is just like we said, tonsillar ectopia, frequently of little significance, maybe associated with a syrinx. They can get hydrocephalus, and they're not going to have spinal abnormalities. And I told you that they sometimes will have to cut part of the back, inferior part of the occipital bone out. Chiari-3 have the encephaloceles. Chiari-4 is a real rare thing. It has agenesis of the cerebellum and hypoplasia of the pons and a small funnel-shaped posterior fossa. That's extremely rare. I've never seen that. So here's a patient, and this is the MRI, and this is T1, and this is increased signal. So what is this probably going to be? It's not contrast. They didn't give contrast. Fat. And you see a tethered cord? The cord goes all the way down here. The cord should stop at L2, 3, definitely not go below L3. And here we have an opening back here. This is a lipomyelomeningocele.
Sir, what on the Chiari's, there's a 1.5 as well. I can't remember what makes it a 1.5.
I don't know.
You know what
I think it's that 0.5 that makes it the 1.5. So it's the lipomyelomeningocele. Here is a very important thing. This might be diagnosed on a cranial ultrasound. These patients, the pediatrician might hear a bruit. The patient might be in heart failure. This is a left or right shunt. And so what we see here, they used to call this a vena Galen aneurysm. It's not an aneurysm, it's a malformation. Look, this is an AVM. Look at all these vessels that are feeding this. And this is the vein of Galen going into the torcula to meet the sagittal sinus and the transverse sinuses and then go into the sigmoid sinus. So this is a vena Galen malformation. And ultrasound, you would want to put color Doppler on it to prove that it's a vessel. Here, these are flow voids on the MRI, so you know that this is flowing blood. And what they'll do is interventional will block off the arterial, more of the arterial supply, not the venous side, but the arterial side, and they will not completely get rid of it because you want some flow still in it, but they'll get rid of most of the flow to it. So you don't completely get rid of it, but just most of it. So this can present with heart failure, and these patients can die of heart failure, just like what in the liver can present as heart failure, and they can die from heart failure in a little baby. Hemangioendotheliomas, infantile hemangioendotheliomas, multiple hemangiomas, and what can happen is these things can shunt, cause a left or right shunt, and give the baby heart failure. And if that's the case, they might have to do a liver transplant. They might have to take them down and embolize these things. If these infantile, which has nothing to do with neuro, but if these infantile hemangioendotheliomas are not causing heart failure, usually within a period of time, they're going to go away completely go away on their own. So here is the MR angiogram of it, showing the AVM, the big vena Galen, and these huge vessels. Here we have sagittal T1s and we have axial T2s. And what do you notice? Did you say hyperintense or these are hypointense in the corpus callosum? A lot of things involve the corpus callosum? No. Tumors that involve it include GBMs and primary CNS lymphoma. They can cause the butterfly. They can cross from one lobe across the corpus callosum to the next. And in this condition, which here, it's a young person. So what do you think this is? Anybody, multiple sclerosis. This is a patient with multiple sclerosis. It's a demyelinating disorder, etiology unknown, affects young adults. MRI is the best to evaluate, and if you want to make sure you look at the cord too. And if they have thoracic spine involvement, they should have C-spine involvement because the cervical spine should be affected before the thoracic spine is, and the brain should be affected before the cervical spine is. So on these, you want to do an MRI of the brain and spine, in the entire spine. And they have symptoms that come and go. They might be blind, and then several months later, they can see and they can't walk. And then they can't talk and they weak. It's terrible.
What's the age of onset of this?
These are young adults. So,
Peds or young adults?
Pediatrician, you see them in peds? Probably older teenagers.
17-year-old.
I would think they'd have to be teenagers or 20s. And they used to think it was much more common up in the north. Do they still think that? The colder areas and more of the Scandinavian descent area? But they don't know why, correct? They don't know why. Why northern colder temperatures? Here is a normal ultrasound of the ventricles. What they do is they're going to use the anterior fontanelle, and they're not going to be going like this to do it. They're going to angle the transducer back, angle it forward, turn it to the left or the right. And what we look for, this is the falx. This black thing that goes from the left to the right is the corpus callosum. This is the cavum septum pellucidum. Nor. It took Nor probably a month to be able to finally get the cavum septum pellucidum, to be able to know the name. She called it all kinds of things, messed it up. Every day she messed it up. And she would go home and talk to her husband and practice it. And then she goes, I know it, Dr. Gates, I know it today. And she would say it, and I said, that's not what it is. And then like near the very end of her rotation, she got it right. She was so proud, so proud. But that's the cavum septum pellucidum. That's normal. That's normal. You and I might have it. Normally when they're full term, it goes away. But it doesn't have to go away. Almost all preemies are going to have it. This is the little frontal horn. This is the Sylvian fissure. We come over here, and this is your head of the caudate. This is your thalamus. This is your basal ganglia with your putamen and globus pallidus. This is the area of the external capsule, and then you have your what is it? Colostrum or no? It's
and then extreme capsule.
Yeah, but what's it called? It's colostrum. It sounds just like colostrum. It's not the milk with all the good antibodies and stuff. And then the extreme capsule, correct. So here, the chori plexus. Here's the chori plexus. Where does the chori plexus not live in the ventricles? It does not live in the frontal horns of the lateral ventricles. And it does not live where in the lateral ventricles? Occipital horns. It does not live in the frontal or the occipital. What it does is in the roof of the third ventricle. It goes to the foramen Monroe. Then immediately goes back along the floor of the lateral ventricles into the body. And then it goes over here to the atrium or the trigone, and then it goes in the temporal. It does not go in the back, and when it goes through the foramen Monroe, it does not go forward. Because acute hemorrhage looks exactly like chori plexus. It's the same whiteness, the same whiteness. There used to be on a test, the residents told me, it said, what is the most echogenic part of the brain on an ultrasound? The chori plexus is what I would say, but the cerebellum, the vermis of the cerebellum is very echogenic too. But I would guess the chori plexus because that's very echogenic. So this is the choroid plexus, this is the choroid plexus. Here's the choroid plexus, here's the choroid plexus. It should fill the ventricle. It shouldn't. There shouldn't be a whole bunch of black CSF around it. And the choroid plexus. What's so important about the choroid plexus? What does it do?
CSF.
Make CSF. Here is then they do the sagittal. Here's the front of the head, the top of the head, the skull, the back of the head, the occipital, the skull base. The eyes would be here. This is the vermis of the cerebellum. This little black triangle is the fourth ventricle. This is the massa intermedia or the interthalamic adhesion. Here is the body, the genu of the corpus callosum, the body of the corpus callosum, and the splenium of the corpus callosum. If there is a black area in here, you want to put color on it because this is where your vena gala malformations would be, right in here. So if you see a black area here, make sure, because it could be a cyst, it could be a pineal cyst, it could be a cystic pineal blastoma. Children get pineal blastomas. So this is the choroid plexus going through the foramen Monroe. Here's the head of the caudate. Here's the thalamus. This is the caudothalamic notch. If you draw a line right here, nothing anterior here should be white in that black fluid because the choroid plexus would come here and then go back. It would not go forward. So if there's white in here, it's blood. Here is the choroid plexus. It's nice and smooth. There's no choroid plexus cyst. I'll talk about that in a second. Here's the occipital horn. There's no hemorrhage in the occipital horn. There's no choroid plexus in the occipital horn. If there was white back in here, it's blood. This atrium can be very big, though. It can be very big. And then it comes over here into the temporal horn. Here comes the temporal horn. And these little white areas are normal. I don't know what they are, but they're normal. And a lot of times you'll see little tiny white dots. That's normal. If you're really worried about periventricular calcification, sometimes you're fortunate enough to see it, but CT is the best way to look. So when they have a microcephalic, peds have microcephalic, they'll often order MRI, head ultrasound, and a lot of times it's just normal. But if you're really worried about torch, they need to do a CT to look for periventricular calcification because we can miss it. This is a different patient. Here's the choroid plexus. Look, there's a bird's beak. So that tells you that this is inside the choroid plexus. So this is a choroid plexus cyst. And if you have a choroid plexus cyst, what is it? The odds are the kid is going to be what? Normal. The odds are the kid's going to be normal. If they're not normal, what is it most likely going to be? It's not Down syndrome. Trisomy 18, Edwards syndrome. And so when they do an OB ultrasound and they see a choroid plexus cyst, or you guys see a choroid plexus cyst, you need to look for any other abnormality, heart abnormality, kidney abnormality, rock or bottom feet, the clenched fist, and the thumb might be in this index fingers over here. I can't do it because I don't have it. They have funny looking heads. But you have to make sure you see both hands open because one hand might open, the other one might be the clenched fist. And so make sure you see both hands open. If the high-risk OB sees nothing but a choroid plexus cyst, they don't offer the woman an amnio because the risk of trisomy 18 is much less than the risk of a spontaneous abortion, miscarriage, from the amnio. But if they see any other abnormality, they're going to offer the woman amnio because now the risk of trisomy 18 is higher than the risk of a spontaneous miscarriage. But when we do it in the NICU, they should say on their history, FLK or trisomy 18, because they see the baby. The babies look abnormal. Trisomy 18 babies look abnormal. They don't live very long, but they have weird looking face, and so when we did the NICU babies, if we see this, it's probably normal because they didn't say that the kid had trisomy 18. Choroid plexus cysts are usually asymptomatic. Approximately 90% will disappear by the 28th gestational week, but they can persist because we know it. We can see them in the NICU. It could be associated with trisomy 18 and 76%. Down syndrome is only 17%. So this is what, 6 times more to have 18. And you can have Klinefelters at only 7%. So the big one to remember is trisomy 18. If there are no other anomalies, 1% will have trisomy 18. So the risk of amnio, the risk of a miscarriage is higher than 1%. I don't know what it is, but it's higher. If there are other anomalies, it's going to be less than 4% because 4% will have trisomy 18, and so they would offer an amnio. So apparently amniocentesis has between a 1 and 4% chance of having a miscarriage. At autopsies, 40 to 70% of fetuses with the trisomy 18 had bilateral choroid plexus measure more than a centimeter. though the risk of chromosomal abnormalities is not linked to the size of the cyst or if they're bilateral. So it could be a smaller cyst and they could still have trisomy 18. And this is what I just already told you about. Trisomy 18, Edwards
What
syndrome.
was the time frame on the ultrasound? What was the week?
Oh,
Or
like
the-
28 by 90% disappear by the 28th week.
What was the one in the, you going? President careful of the ultrasound, I just read it tonight.
This is just that's when you get your the anatomy scan. Trisomy 18 has decreased maternal alpha fetoprotein, decreased HCG, and decreased estriol. OB ultrasound, intrauterine growth retardation, which can be severe, a single umbilical artery. Whenever they have a two vessel cord, they'll always order, what do they always order that we have to read? Renal ultrasounds. They'll order a renal ultrasound because there's associated renal anomalies with a two vessel cord. And they may have polyhydramnios. The clenched hand, overlapping second finger, I demonstrated it to you. That's highly classic. But please, on OB ultrasounds, look. Oh, guys, please. In the real world, if she's the ultrasound tech, okay, I'm the ultrasound tech, she's the doctor. I give her a sheet, the request, and I have a sheet that I fit pancreas normal, liver normal, block normal, kidney normal. And I hand it to her. And in the real world, some radiologists just maybe scroll like super fast. And when they dictate looking at that report with her. We had a resident that he was called the legend. And if you don't believe me, I've talked to you about this. I'm not talking to the ladies about it, but you can talk to Dr. D. He called him the legend. But all he cared about was money. And he goes, Dr. Gates, I'm going to work my ass off and be a millionaire and then quit and then just invest and retire. And so the first year he didn't join a group. He did locum tenens and went all over the place, all over New York. Every day he worked every day because he's young. You know, y'all are. He's a man. He's pig-headed. He thinks he can do whatever he wants, and he made a lot of money. But one time he said, "Yeah, there was a fetal demise case," and I said, "Yeah, you didn't see anything?" He goes, "Well, the tech told me there was a fetal demise, no heart activity." I said, "You didn't go in there and look at it yourself?" He goes, "No." I said, "So you called it fetal demise based on what the tech said? You know that is totally wrong. It's against our quote radiology religion. You have to go in there and look at it yourself. Two people need to witness that there's no cardiac activity, and you got to watch it for a period of time. I forgot how long, like 3 to 5 minutes, watching that heart that is not moving. You can trust the tech, but you don't trust the tech. You're calling that they're going to get they're going to give them something to abort the baby, or they're going to do a DNC. And then wouldn't that be horrible if that really there was activity and the tech just missed it? So don't. I don't know. I wasn't there. He was telling me. I said, no. I said, you've got to go in there and look at that. You are legally and morally responsible to go in there and look at it. So make sure that you look at it and just don't read what the text says. Don't read what the text. Think of every one of them as being Jackie, or every one of the texts as being Rat-tail Jackie, or being VD. Okay. Think of every one of them like that, and you don't trust them. Look at the images, please. Look at all the images. We want you to be great radiologists. We don't want you to be all about the money and not caring about the patients. Because these trisomy 18 can have facial clefts, abnormal shaped head, cystic hygromas. What other not uncommon condition gets cystic hygromas? Turner's. What else do they Turner's classically get? Coarctation aorta, and what else? Yeah, of course.
Broad chest, widely spaced nipples.
Shield chest. What about the kidneys? Horseshoe kidneys. That's good. What about in the hand? A limp. Short fourth metacarpal. That's, remember, Turner's. Also normal. Pseudo hypoparathyroidism and pseudo hypoparathyroidism. Micronathia, they get real little tiny mandible. They can have holoprosencephaly, club form in foot. Rocker bottom feet is that's classic. congenital heart defects in 90%, diaphragmatic hernias, omphalocele, polycystic kidneys, horseshoe kidneys. Here is a head ultrasound. This is the coronal. This is the sagittal. Here we have the nice. What's this little piece of the corpus callosum called? Rostrum. They can ask you that on your boards in normal anatomy. Here's the genu, the body, the splenium. What is this? Which part? Vermis of the cerebellum. This is midline. And so on the middle, this is the massive intermediate interthalamic adhesion. You know what this is right here? That's the third ventricle. That's the third ventricle. And it looks big here because you're catching it like this. The third ventricle when you do these are real small. See how small it is? But if you caught it like you should right in the midline, it's going to look real tall, and it extends back here. What's it called when the cavum septum pellucidum goes a little bit further back? Cavum septum vergae, and then when there's one way back here underneath the cavum interpositum. Cavum septum interpositum. So is this chorioplexus? Is this chorioplexus? What is it? And so what are the grades? Grade 1. Grade 1 is right here at the caudothalamic notch. That is the classic germinal matrix hemorrhage. Grade 1. This is a grade 2. It's in the ventricle, but the ventricle is not dilated. Grade 3 is when the bleed in the ventricle causes hydrocephalus. The bleed has to cause hydrocephalus. Not a little tiny blood clot obstructed the foramen Monroe and they get hydrocephalus. That would still be a grade 2 hemorrhage with associated obstructive hydrocephalus. Okay? The blood has to make the ventricle get bigger for grade 3, and then grade 4 is when it goes into the brain parenchyma.
So for grade 3, the blood would distend the ventricle?
There would be so much blood that it would make the ventricle big. Because you can often have a grade 2 hemorrhage, and then on the follow-up, there's hydrocephalus now, but the blood is the exact same. So what happened is a little piece of blood blocked the foramen Monroe, and so it's grade 2 with now associated obstructive hydrocephalus. Here we have bilateral. The chorioplexus never looks like this. And initially, all blood is going to be real echogenic, real white, and then it's going to start getting black. And is it going to get black more in the periphery or in the center? It's going to get more black in the center first. When the evolution of the hemorrhage, the clot, it'll be echogenic, and then it'll start getting patchy hypoechoic areas when it starts, and then sooner or later it'll be all black. But when it goes into the brain parenchyma, what's going to happen? What are the patients going to get? Okay, that's a little different. They're going to get porencephalic cysts. Porencephalic cysts are when you bred into it. You bled into the brain, and now that brain parenchyma is dead, and so when the clot resolves, there's going to be a cyst that will communicate with the lateral ventricle. That's a porencephalic cyst. Periventricular leukomalacia will not communicate, and that's usually due to a little bit of ischemia. And initially, it's going to be echogenic. Can whoever call 61483? 61483. So this patient right here has a right-sided grade 4 hemorrhage and a left-sided grade 3 hemorrhage. You see this, John? How thick that blood is? That made the ventricle big. This is grade 4 because it's out here in the brain parenchyma. And so this person's going to, grade 3s and 4s are bad. Poor prognosis. Grades 1s and 2 aren't that bad. And here it is again into the brain parenchyma. Here is a trauma patient. And so first year.
Can I ask you a question real quick, sir, on the ultrasound stuff? The streaking of like periventricular...
the whiteness.
Yeah.
Initially, you can call it the flare phenomenon and a repeat flare and repeat it in like a week. And to be periventricular leukomalacia, because periventricular leukomalacia starts off echogenic. And it can stay echogenic, and that's grade 1. Then it can start getting mixed echogenic and lucent actual holes, and that's like grade 2. And then the higher the grade is when it becomes just cyst. For that, correct, if they're the preemie babies. But it has to be the same echogenicity as a chorioplexus. If the chorioplexus is whiter than that periventricular stuff, is not PVL. The PVL will be as white as the chorioplexus. So when you have the lateral ventricle, you look and say, my corneal plexus is wider than that, so that's normal. Because there's always going to have white stuff out there. Yes, ma'am.
I just wanted to read on a chest X-ray.
Okay, did you tell them I'm almost done? Thank you. And so, mammally, what is this?
Epidural.
Epidural what? Yes, sir. Yes, sir. And yesterday at the conference, do you remember that Embry, Dr. Embry, the older man, said, aren't you a little, given the amount of edema, aren't you kind of surprised that there's not bowing of the falx? There usually isn't bowing of the falx. The falx is a rigid thing, very rigid, and it acts like a knife. And so what happens is you get subfalcine herniation, and that can like shear and cause a lot more damage because of that. And here, look at this. This is, the falx is right in the midline like it should be. So that's why I said what I said, because he's acted like there should be, the falx should be bowed over too, but it's not. But this is severe. This is severe right to left midline shift, and due to this huge epidural. And these are going to be venous or arterial? Arterial. Is this an emergency? Absolutely. Is this, can this cross the midline? Can it cross the, I didn't say sutures, can it cross the midline, an epidural? Yes. Can it cross sutures? No. They love this on the test, I'm sure they do. At least the subdural will not cross the midline, but it can cross the sutures. Okay? So think about it. Here we have, this is being, the suture stops this, but here there's no suture in the middle, so it can cross the midline.
The periodicum associated with the suture.
Acute epidural hematoma. Here is, I'll stop here, and this is next time I think when all of you guys are here, I'm going to do board review, but I might start brain tumors whenever. So thank you guys.